Hi, my name is Kathryn Gunther, and I'm a genetic counselor. A lot of people in the TANGO2 community already know what a genetic counselor is, but my main jobs are sharing information and sharing support with patients and their families in this wild world that you kind of get thrown into with genetics. I am actually a volunteer with our outreach committee. Really long time ago, I had a patient with TANGO2, and they really touched my heart, and I realized how special this community is. And so because of that, I wanted to join the outreach committee. And the Tango Foundation is so amazing because they're always looking for new ways to share information with families and fill gaps that people have. And so together we've kind of created this presentation where I will talk about all of the words that you might hear from your doctors and your different specialists and kind of explaining what those mean. So that way, we can help families and other care providers really understand the care for Tango2. And so, I'm going to start with a disclaimer. I have no financial obligations. I'm not getting paid to get this talk. I'm just here to volunteer, but I am mentioning a lot of medical concepts and terms, and none of those are specific medical advice. If you watch this and you have any questions, you should always talk to your physicians about specifics for your child and your child's labs. So first, what I want to do, number one thing is define all these kind of words that you'll hear from medical providers. A lot of them are interlocking and deal with the same things. And so if you don't know one word, you might not know 10. And I also want to talk about how these overall relate to your child's health. So to start way at the beginning, probably the first thing that you learn, what is TANGO2? So TANGO2 is a gene in the body, and many people might remember back to their studies in school. All of our body is made up of trillions and trillions of cells. Those cells all have a little headquarters in the middle called the nucleus, and that is what holds all of our information. We condense our information into chromosomes. Those are the structures that hold our DNA. And then a specific unit of DNA is what we call a gene. So that's an instruction that performs a very specific job in our body. And TANGO2 is an acronym for the very specific job that it does, which is transport and Golgi organization. And I put a little zoom in of a cell so you can see what a Golgi is. But the big idea is that it's kind of like a train. It functions to get information from the nucleus out of the cell. So all of the Golgi and everything else is moving things away from the center. So kind of like a train really operating in transport. You might also hear that TANGO2 is a genetic condition, so it's inherited. That is true. This condition can be inherited from parents. We're all carriers for genetic conditions, and what a carrier is someone who has a typical copy of a gene and then a changed copy that doesn't work. And so the only issue that happens is when two carriers of the same condition find each other, there is a chance they both pass on their non-working copy. And so when we say autosomal, that refers to the fact that any child of any sex can have this condition, so boys and girls, as many families already know. And then recessive, referring to that they have to both inherit that changed copy. So you might end up with children that have that carrier complement, so a changed and a typical copy, or even kids that are not carriers at all. But about 25% of the time, you'll have an affected child, which is the risk for all recessive conditions. And if you have started to research on TANGO2 at all, you might have heard of it by its previous name, which is MECRN. The first paper that ever described this condition back in 2015, 2016, described it as an acronym of the most concerning features that originally brought patients to attention. So metabolic crises, recurrent rhabdomyolysis, cardiac arrhythmias, and neurodegeneration. So MECRN. But since that time, we've figured out more patients have TANGO2 and that it's actually a spectrum of disorders. Some people do not first come into care with a hospital ER visit. Sometimes they have developmental problems. And so because it's a spectrum, it can also be called TANGO2 related disorders or TANGO2 for short. So that's the new name, and that might explain why you've seen this acronym a lot of places. So I want to break down the acronym specifically into each part so that way we can better understand TANGO2 as a whole. Especially the acronym might not describe everybody, but it definitely describes concerns that you're going to hear from providers. So to start at the beginning, recurrent metabolic crises. Metabolism is what our body does every day. There's a very specific order of how processes go in our body. And we have to break down fats and convert sugars into energy. And that is what we typically do all day, every day. What a metabolic crisis is something that breaks up that normal action, and then we end up with too much and too little within our body. And so that is something we see in patients with TANGO2, and it's often one of the most scary things. And so whenever you go to the ER or see your doctor, they're going to order a specific set of labs because we know what this crisis looks like in people with TANGO2. So we'll see most often that they'll have low sugar, and then you're going to get a buildup of other byproducts. So the first test they're going to run is a glucose. That checks the sugar. What they're looking to see is if the patient is hypoglycemic or has a very low sugar, less than 60. And that number does change depending on your age. Some kids have, I think it's less than 45 for infants is considered hypoglycemia. So could depend on age. Then they're going to look at what those buildup of other byproducts could be. So they're going to look at a lactic acid and an ammonia. And what they're looking for there is lactic acidosis, or a high lactic acid above 2. And they're looking for hyperammonemia, which is a high ammonia, which is anything above 100. And the reason they look at all these labs is to determine if you're in a crisis and how bad that crisis is. So these are going to be the first things that you're going to order. They should be in your hospital letter, and they're very important to kind of examine and see the state of metabolism. And metabolic crises look different for everyone. I'm always a huge champion of the fact that parents know their kids better than any doctor ever could. And so you know when your kid is acting funny. And so even if they might not present in some of these classic ways, if a person is acting different and they have TANGO2, we might want to think about taking them to the ER. So because everything is messed up with the metabolism in the body, sometimes your body will react in a specific way. And the most common things we think about are vomiting, which is why I have that picture of that little girl with a bucket. Sometimes kids just vomit and it's not a big issue, but we also worry when kids are vomiting because they're not eating. They're throwing up everything that they're eating, and maybe that's increasing a fasting time for them, which we'll talk about later. We might also see kids be lethargic or really sleepy. They won't wake up to eat. They won't wake up to do their favorite things. They just sleep all the time. That would be an abnormal behavior, as well as what we'll call ataxia, and we'll talk about it a little bit later. But some kids, especially kids of walking age, might be wobbly, might be unsteady, but we'll talk about the other signs that count as ataxia if your child may not be walking or talking yet. So now in MECRN, the R stands for rhabdomyolysis. And so if we break down this word, rhabdo actually means long, thin rod, myo means muscle, and lysis means death. And so the muscles of our legs and our longer limbs are created of long rods, so long rodded muscles. Will start to break down. And this can happen from direct injury. So for example, if someone's in a car accident, we worry about rhabdomyolysis, or it can happen from indirect injury. So for example, a metabolic crisis may cause your body to break down its muscle and break it down in a way that is not safe. Because when those muscle fibers start to break down at an increased rate, they're going to release their contents into the bloodstream. And what that does is it goes straight to the kidneys. The kidneys' whole job is to filter out toxins. And so when it is being attacked with so many toxins, it can't filter everything out. And you'll end up with what many people will call Coca-Cola urine, or very dark urine, because it's not filtering out toxins. And we measure the rate at which this is happening because everybody can have a little bit of rhabdomyolysis happening in their body, but we worry about it when it exceeds a certain threshold. And so what we will do is look at creatine kinase. This is a very specific thing that is broken down in rhabdomyolysis. And so we tend to see people be under 200, but we call it an increased CK when people are above 200. And when this is really, really bad is when we can see it in the hundreds and the thousands. And we do have patients who appear like that. And that just reflects the amount of muscle that is breaking down. And we know the most concerning thing is how that will affect the kidneys. The C is for cardiac arrhythmias. So just like with metabolism, our body has very many things it likes to keep in a specific order. Our heart rhythm is one of them. Our heart is supposed to beat in a very predictable way. It's this PQRST wave that you see there. That's the typical way that our heart will continue to beat. But sometimes we can see irregularities or changes in how that heart rhythm is happening. Usually this coincides with being sick or having a crisis. And the most common one that we'll see is what I pointed an arrow to. It's that QT prolongation, so increasing that distance between Q and T. And the biggest concern with that is that our heart has a very particular rhythm, and if that rhythm changes, it's more difficult to get it back to the original rhythm. A Brugada type pattern is a very similar pattern, but it looks more humpish. All of them are just concerning for the same reason, though, that we are changing the rhythm of the heart and we got to get back to what it was. The last letter, the N, is for neurodegeneration. Again, we're going to break it down. Neuro means brain, degeneration means the breakdown of. And so when we're worried about kids with changes in development or learning, what we're worried about is maybe that the brain looks different. And so magnetic resonance imaging, or an MRI, is what we might do to see the actual picture of the brain. And any change in that brain tissue could result in a loss of tissue. This is especially true because, like I talked about with the lactic acid and the ammonia, those things, especially in large quantities, can be harmful to the brain and cause this breakdown. Not every single kid with TANGO2, we see this breakdown of the brain, but we just know that there's a possibility it could be there, especially if we're seeing multiple crises with really high lab values like I talked about. The most common places that we're going to see changes in the brain is in the ventricles, which are those communications between the halves of the brain. And we can also just see loss throughout the whole brain. And so those pictures of the MRI, what we most typically see a brain look like is on the left side. And then the right side actually reflects the same brain over time and how it's having atrophy, or there is neurodegeneration or breaking down of the brain tissue. And so this is a physical way you might have your child getting MRIs over time, is to look at what the brain looks like and if there's any deterioration, because not every single crisis is going to be picked up by a child acting different. You might not go to the ER for every one of them, but they might be changing the structure of the brain. You can also measure neurodegeneration, not only with a picture of the brain, but in a measure of the brain waves. And so an EEG is something we use to measure those brain waves. And when we see changes in the waves, kind of like everything else, there's a specific order that the brain does everything in. The left side is more what our brain waves typically look like, so those little up and downs. And then when we see large changes in the waves, so big ups, big downs, no repeatable pattern, that's what we call encephalopathy. And that means that the brain is not firing in the correct way, and actually most of the time it's firing in an incorrect way. And so sometimes you might not have physical damage to your brain that we can see, but we can see that the brain waves are not typical. And when that happens, we worry about things like delays and trouble with learning, because if your brain's not firing the way that it's supposed to, you're not going to be able to make those connections like other kids are making. So you might not talk at the same time. You might not learn at the same speed. And so an EEG and an MRI are both different ways to look at your brain and how it's behaving. And any kid, especially kids with genetic conditions, might get these for one reason or another, and it's just to measure and explain what's going on. Other things that perhaps a doctor or hospital might look at are other signs of muscle injury. So I don't know if you remember from the Rhabdomyolysis PowerPoint, there were myoglobins and other things that were broken down whenever the muscle tissue started to break down. And two of those things are transaminases and aldolase. They both have very important jobs of converting things in the body. And so when a muscle is injured, it's going to release these, it's going to be really high. And we also know that the transaminases and aldolases aren't doing their job because they're just being released into the body. Additionally, they might look for an acidosis, like I talked about with lactic acidosis, or seeing a high lactate. Whenever you have something really high in your blood, you might also secrete it through your urine. I don't know if anyone's ever taken vitamin C. If you already have enough vitamin C in your diet and you take a vitamin C tablet, if you go to the bathroom, it might smell like oranges, and that's because of the specific process that your body, when it has too much of something, it just excretes the rest in your urine. And so when you have too much lactic acid in your body, you're going to excrete the rest in your urine. And so that's just another way to prove that the lactate is very high, and specifically it's so high, it's going off in other ways in the body. They might also look at what we call acylcarnitines. These are chains of carbons, and we call them specifically fatty acids in the body. They're things that you might break down for energy, and we name them very simply. So a C14 has 14 carbons, a C6 has 6 carbons, and we measure them in what we call an acylcarnitine profile. These are often measured both in the ER and not in the ER, just at your regular doctor's visits, because we see kids who have TANGO2 have elevations in C14 and C10. So that means that they're not breaking down those really long chain carbons for energy. And those are great carbons. They're very long. They have a lot of energy within them. And so when you're not breaking those down, we're going to see increases in the body. And that lets us know that something is going on. So sometimes doctors will want you to have a baseline. Oh, this is always what Katie's acylcarnitine profile looks like. And then this is what it looks like when they're sick. You're able to measure those changes. So that was me talking about the MECRN part of TANGO2. But as I talked about before, TANGO2 is very much a spectrum. Every kid looks differently. Not everybody has every problem. And so you might hear other words talked about. And so I want to make sure that everybody's up to date on those as well. One more disclaimer, again, I'm mentioning many medical concepts and none of them are advice. And if you have any questions, you should always reach out to your doctor. We're definitely going to take questions in the comment section, but if they're very specific to your child, I'm probably going to tell you to reach out to your physician because everyone is a little bit different and I'm definitely not equipped to handle that. So the first word, like I talked about before, was ataxia. So this is an unsteadiness or an uncontrol of bodily movements. Some people, it is most obvious when we talk about coordination. So if your kids are walking, you might see that they become wobbly, where they normally don't walk with a wide gait. They might suddenly start walking very wide and falling over more. That is one of the most common things we see when kids are getting near or in a crisis. Is that unsteady walking. But like I said, not everybody is walking, so that can be really hard to see. But you can have ataxia with other issues within the body. For example, your eyes, they might have changes in how they move, or with your speech, it might become slurred. So even if you're just making sounds, you might be able to tell from these small movements that even if you're not walking, you can tell they're abnormal. And that's why I always say parents are the best at understanding their children because they know what is normal and then what does not feel normal for them. Neurologic changes, even though they can be measured with an MRI and an EEG, and then EEG is actually what we use to detect seizures. I wanted to just explain what seizures are and what epilepsy is, because I think they're very interchangeable and sometimes doctors will just throw out both. But a seizure is a single, sudden, uncontrolled electrical disturbance in the brain. To bring you back to the EEG, you might see a bunch of little mountains and then one big spike and then a bunch of little mountains again. That's what we typically think of a seizure, is a single event of a change in the brain waves. This can happen for any reason or perhaps an unknown reason. Lots of kids will have febrile seizures or seizures whenever they have a fever. And so sometimes we can explain a single seizure, sometimes we can't. But when we see seizures recur, and we think they recur for a very specific reason, for example, a genetic condition, that's when we say that someone has epilepsy. About 75% of kids with TANGO2 will develop epilepsy. It's usually very well controlled on anti-epileptic drugs, but it is that recurrent disturbance. So seizures that happen for a specific reason, that specific reason is TANGO2. You can have a seizure without necessarily having epilepsy if you only have one, or if it has an alternative explanation like a fever or low calcium. And so those might not be classified as epilepsy disorders. They might just watch your child more closely. So that's the difference, is one time it can even be unexplained versus many times with a reason. Another thing that your doctors might talk about is hypothyroidism. This affects about 1/3 of people with TANGO2. And what it is your thyroid is underactive, which is kind of odd because you'll see in the picture that a thyroid that is hypothyroid is very big. But just think about it as not doing its job. And so it gains a little weight. And what your thyroid is responsible for doing is releasing hormones, particularly thyroid stimulating hormone T4, as well as hormones that your body uses throughout. And so when your thyroid hormone isn't working, what you're going to see is high TSH and low T4. This might just be something that kids will get in a yearly lab to make sure that the thyroid is still functioning. But you can also bring it up, especially if you're concerned about changes in behavior. So again, for example, if your kid is tired more frequently, if you're seeing changes in puberty, like maybe they haven't had puberty yet, or they had puberty really early, or even some kind of superficial things, changes in the hair, whether it's dry, you're losing more of it, changes in your nails, they might break more easily. All of those things can be small signs that your thyroid isn't working correctly. And this can be a pretty easy problem to fix with thyroid medication. So it's important to know about it early before it causes a problem. And that's why they check for it pretty frequently. Intermittent dysphagia is another thing that might be of concern to families. Intermittent means not all the time, it's just something that happens every now and then. And dysphagia is difficulty swallowing and potentially having food go down the wrong pipe. I don't know another way or the sciencey way to say that. I just say that food is going down the wrong pipe. And what that's concerning for is that if you're eating or you're drinking and it goes down the wrong pipe, what that means is instead of going to your stomach, what it's doing is going to your lungs. And if you get water or food in your lungs, that's what we call aspirating. And aspirating can actually affect how your lungs behave. So they can get infections, they can have damage, and so we don't want any of that. So even dysphagia every now and then, so that issue with swallowing, could potentially put you at risk for aspiration. And especially in kids with TANGO2, where we try to avoid being sick as much as possible, we don't want to give ourselves a risk for a lung infection. And because of that, intermittent dysphagia can not be a big deal if it's happening very, very not very often. But if it's happening more frequently, that's when kids might consider getting something like a G tube. That way we can avoid feeding through the mouth and we can mostly feed through the stomach and really protect the lungs. So that's an option, and perhaps why some kids might end up getting a G tube or a tube to feed through the stomach directly. Dysarthria is a speech disorder, but it's not caused by a problem with learning. It's not a speech delay. It's an actual issue with the mouth and the voice box and the larynx forming words. A lot of people can appreciate looking for a word and trying to think of it. Dysarthria is kind of like that, except it's not in the mind. It's your body is trying to form a word, and it can't create that word. So it's an issue with physically articulating the words. So people might speak very slowly and very exactly so they do not mess up, or they might slur their speech because, again, those muscles there are not allowing you to speak correctly. So it's not a form of speech delay. It is an issue with how you speak, but we would treat it the same way. We would try speech therapy and different methods within that, so that way we could hopefully get speech to a normal speed and still have it be very exact. And kind of that goes into what we talk about with changes in milestones. So a lot of people, like I said, might just be picked up because they have developmental delay. What that means is that we have a prediction of where most kids will develop particular skills. So most people know a typical kid might walk or talk at a year. From the medical standpoint, we have a window in which we expect kids to walk and talk. For example, we expect most kids to walk between 10 months and 16 months, and you get that whole window to do it in. But if you're not within that window, so if you're delayed, you will achieve most of your milestones outside of those typical windows. And then we measure it by severity. So how far are you outside of that window? And when you're not meeting those developmental milestones, what we worry about is when you might meet them. And so the big things that we give to children are therapies, so speech, physical, and occupational, to help them reach those milestones as close to the typical window as possible. That is different than developmental regression. So developmental delay is not meeting those skills in the window. Developmental regression is when you have a skill and then you lose it. So you previously were able to say mama, dada, baba, all of those words and use them meaningfully. And then maybe you get sick, you go in the hospital, you're sick for a few months, and when you come out, you can't say those things anymore. That is a regression, so it's a loss of skill. And these can sometimes just be situational. Like I said, if you have a crisis, you got to rebuild those skills when you get home from the hospital. It's not typical that these kids will just lose these skills and have them stay lost. That's not what we typically see. Torsade de Pointes. I know I already talked about cardiac arrhythmias. This is just another specific arrhythmia, and it's one of the ones that gets thrown out with TANGO2 a lot. That's literally French for twisting of the points. And if you remember, I don't have a picture of it, but if you remember what a typical PQRST wave looks like, there's an up and a down and a break, but right here, you're just gonna see up, down, up, down, up, down, and that's that twisting of points. There's no identifiable heart rhythm. And just as with previously it happening, our worry is we want to get it back to that typical heart rhythm. We don't want it to be out of whack. And specifically what happens in torsade de pointes is what we call a ventricular tachycardia. So that's when the ventricles, or the lower part of the heart, just start beating back and forth rapidly. So it's just 1, 2, 1, 2, and that's the wave that you end up getting. It also causes a quickened heartbeat, which can be greater than 100 beats per minute, when typically a heart rate might be more around 60. And so our worry is that we're using the heart too quickly and we're getting away from that typical heart rhythm, and we want to get it back. These can be one of the most scary things that we see in a crisis, because this heart rhythm is really hard to control. And so when people talk about this heart rhythm, it's very concerning. Another thing that your doctors might talk about is intermittent exotropia. Just like last time, intermittent means it happens every now and then, but not all the time. And exotropia is a misalignment in the eye. So exactly what you see there, the eye rotates outward. And this can happen in one or both eyes. And it's kind of like the opposite of your eyes being crossed. Instead of them going in, they're going out. This can be particularly concerning, like I talked about with seizures and epilepsy. If your child has a history of seizures, or if they've never had a seizure, when people see changes in eye movements, they often get very scared of the concern of seizures. And I think that's very natural. You should always bring it up to a doctor and have it worked up. But the main reason that we call this intermittent exotropia and not a feature of seizures is that they will do an EEG, they'll measure those brain waves, but they won't see the eye movements correlate with any brain activity. So it's just the eye moving, it's not any changes in the brain, and it's not a seizure. And that's when you can say it's intermittent exotropia and not a seizure, as when it doesn't correlate with that brain activity. And so, the first time it's quite scary, but then after a while, you just know, oh, well, this is something their eyes do occasionally. It is not a larger problem. And I know that, probably a big thing that every family thinks about once they get a diagnosis of TANGO2, they hear about the metabolic crises, they're quite concerned because they get a hospital letter and they get all this information. And so they're like, well, how can I fix, how can I make sure my kid never has a crisis? And there are a lot of things you can do, but there are also a lot of things that you can't. So we know kids are more prone to crises when they're sick. That's because the metabolism in the body is already off, because they're sending so many troops to kind of fight your infection that they don't have enough to perform their typical activities. So because of that, being sick is one of the biggest risk factors. If we could all wish that our kids would not get sick, we would, but as everyone who's used a daycare or a nanny knows, sickness just travels and it's an unpreventable thing of life. But there are some things that we can do. So we typically think about kids not fasting or keeping them very hydrated. That's because, like I said with metabolism, it's our body's normal way of doing things. And so in times of fasting, your body starts to use different ways for energy than maybe it typically would. So the best thing that we can do is to avoid fasting and stay hydrated, because in times like that, we're using our typical metabolic pathways and nothing should be different. Another way to think about this is maybe eating foods that take longer to digest. And so an example of that is complex carbohydrates. So these are carbohydrates that are very dense, very long, very hard to break down. And so over time, if you eat a lot of these dense, complex carbohydrates, it's going to take your body longer to break them down, and you're going to decrease your periods of fasting because you're still going to be breaking down food from lunch while you're eating dinner. A lot of things like being sick will mimic fasting or dehydrating. Kind of like I said before, if your kid's vomiting, if your kid's refusing food because they're sick, that kind of mimics fasting, which is our big concern in TANGO2, and everybody handles it differently. Definitely talk to your doctor about it. But one thing that I know we use in our clinic to talk about fasting is cornstarch. Some people don't know what cornstarch is, or they definitely don't think about eating it, but cornstarch is a way to increase or rather decrease the time in which you're fasting. So cornstarch is one of these complex carbohydrates. It takes a long time for the body to break down. And actually my rule of thumb is that cornstarch can add 1 to 2 hours on your fasting time. So a lot of people will do fasting intervals, and then as kids get older and bigger, they'll increase that interval as much as possible. We know, any parent knows, that sleep is very hard to come by, and specifically sleep at night. You want your kids to be able to sleep for as long as possible because it means you're able to sleep for as long as possible, but also because they're getting more restful REM sleep. And so sleeping is the big time we see kids most often fasting, because we want them to fast for longer because we want them to sleep for longer. And so what a lot of families might do is use cornstarch. This can add those 1 to 2 hours to your fasting time. So for example, if I normally sleep for 8 hours, if I eat right before I sleep and right before I wake up, then I will have only fasted for 8 hours. But if I take cornstarch right before I go to bed, and then I sleep for 8 hours, I've really only fasted 6 to 7 hours, because that cornstarch I took right before bed is still breaking down in my body for 1 to 2 hours while I'm sleeping. And so cornstarch can be something that really helps extend the time kids can sleep, which is the time kids can fast. So a lot of families find this really helpful, especially if they're worried about fasting. And then the last thing that I wanted to talk about is what hospital plan looks like. So a lot of people, I want to say you guys get a hospital letter when you join the TANGO2 Foundation as a part of their family welcome kit. But the typical idea of a hospital plan is that your kid is sick. Your kid might not be acting typical. And so what we do is we want to get them to the hospital. And like I said, the first thing they're going to do is check their glucose. And that's because if it's low, we know everything else might be changed because of it. And so if your glucose is low, what do we want to do? We want to give you sugar. So that's what dextrose is. It's that sugar that's going to help raise your body's sugar and get your metabolism back to normal. And so this is glucose through IV nutrition, so intravenous nutrition. So especially, like I said, if your kids are vomiting, if they're refusing food, if they're sick, we just go ahead and put an IV in, give them all the sugar they would be getting, and then we end that fast and give them as much sugar as possible to bring all the labs back to normal. You might see on there what we call a GIR, or a glucose infusion rate. That is the rate at which we want that patient to get sugar. Typically, there's a normal rate for kids. I want to say it's around 7 to 8, where they should be getting their glucose in that amount. And that's 7 to 8 milligrams per kilogram per day. So that's how much sugar they want per kilogram of weight per hour over the course of the day. And so that is typically what they might write in a hospital note, is give this patient IV glucose at this GIR, we want this amount of dextrose, and that's just a very specific plan for your ER physicians to follow. But the whole goal is that they want to end the fast and they want to give you sugar so your labs can get back to normal. Sometimes what you might hear, or if you go to the ER and they take a sugar and it's very low, undetectable, less than 20, what you might get is what we call a glucose bolus. So they're just going to give you a rapid amount of sugar. They're not going to let it drain from an IV. They're just going to give it to you. And that's to get the sugar immediately up to a detectable range. But then they might put you on what we call 1.5 maintenance. So a maintenance dose is a typical dose for a typical body mass. So what you would give any person who walks into a hospital and needs this, we give them that dose. That's considered maintenance. When we do 1.5 maintenance, that's 1.5 times the typical dose. So that's what you're going to do when we want to make sure you have enough glucose and enough fluids. So if you haven't eaten anything in a day, if your glucose is undetectable, that's when we might say, oh, they don't just need D10 or 10% dextrose, they need it at 1.5 maintenance. They need it at 1.5 times the normal rate because we're concerned about their sugar. So that might be what you hear in very specific cases of low sugar, or some physicians will just do this from the get-go. They won't tell you to have D10 at maintenance, they'll just start off at 1.5 maintenance because they know that these kids will need more sugar than other kids. And so that was everything that I had, all of the words that I could find to define. If you guys have any questions or any more words that you want me to talk about in a future video, I'm happy to look at the comments and give you as much information as possible. Like I said, none of this is necessarily medical advice, but when people start throwing out these words to you, I want you guys to feel empowered and ready to talk about them yourselves with your doctors. A lot of people end up being an expert on TANGO2 after their kid or their family member is diagnosed. And so I want you guys to feel like the experts that you're going to be, because you might be in a place where you're the only person who knows about TANGO2, but that doesn't mean that you're uneducated about it. It actually means you're probably the most educated. So I'm so happy to give this talk and hopefully going to give a lot more in the future. But thank you guys so much. It was such a pleasure.